In HIV, it took us a long time, but we persisted. The first level of surrogate endpoints there were CD4 counts. And we failed for many years because that was an indirect measure. Then when we had the technology to understand viral load, yes, that's the principal causal pathway, is having antivirals to reduce viral load. The combination of that biological understanding with then, as Greg Levin was indicating, we need to have the clinical trials that ultimately are going to give us the meta-analyses. It's a combination of having that clinical data that allows us to identify what are the very likely principal causal pathways, having interventions and understanding with the plausibility that they're going to have positive effects on those pathways. But to be fair, what could their unintended effects be? And because that's an inexact science, putting that together with meta-analyses of trials. So in other settings where successes have been achieved, it didn't just happen. It happened with an aggregation of all of those approaches and the ability to be disciplined and to gather the evidence over time. And as you said, we need to have some trials that are positive and some less positive to understand the distinction between what were the biological effects that led to clinical benefit versus the ones that didn't.